Mother-to-child transmission, or vertical transmission, is the dominant mode of HIV infection for children. In 2019, Nigeria alone accounted for approximately 15% of vertically infected children living with HIV globally. Hello and welcome to this episode of The Last Mile with NACA. I am Adesuwa Osui. Low access to and patronage of antenatal care and health facility delivery, which are two major platforms for preventive mother-to-child transmission service delivery, contributes to low HIV treatment coverage rate in spite of available services. The Mentor Mother program has been identified as a key strategy in the global plan towards the elimination of new HIV infection amongst children, as well as keeping the mothers alive and healthy.
In Nigeria, as in many countries, prevention of mother-to-child transmission (MTCT) services are primarily facility-based, requiring clients to continuously access healthcare facilities for care and treatment. However, the implementation of this program has been especially challenging in rural areas with low maternal health service utilization. When they do access healthcare facilities and are tested positive for HIV, the emotional distress, fear of stigmatization, violence or abandonment can lead to poor maternal adherence to antiretroviral therapy, which increases the risk of MTCT. The Mentor Mother program ensures that such women are provided the needed psychosocial support right from time of diagnosis and sustained throughout, facilitating their retention in care and complete access to needed services for them and their exposed babies.
Since 2004, IHVN have been supporting NACA to offer HIV services to those infected. This includes the PMTCT services, prevention of mother-to-child transmission. And the PMTCT program in IHVN is built on 4 prongs. The first prong is to prevent transmission of HIV to women of reproductive age. The second prong is to prevent unintended pregnancy among women that are HIV positive and are within their reproductive age. The third prong is to prevent mother-to-child transmission of HIV among women who are already infected with HIV to their unborn babies. And then the fourth prong is to provide care and support services for women infected with HIV and their family at large. And in trying to meet the needs of these women, we discovered there is need to bridge certain gaps in the PMTCT cascade that was identified. And some of these gaps are denial in women newly infected, fear and discrimination, not wanting to adhere to medications and treatments for HIV, either based on lack of knowledge. And so because of that, we felt we needed people that have passed through the PMTCT program that could serve as role model to those that are newly infected and even those that are previously known infected, HIV-infected women. Those that could freely talk to these women, counsel them based on experience and not just out of book knowledge. And so that was what gave birth to the Mentor Mother strategy.
A mentor mother is usually recruited from the pool of experienced members of mother-to-mother support group of each facility to ensure familiarity with the health facility, the adjoining communities, and the other HIV-positive mothers.
So the mentor mothers are carefully selected based on certain criteria. The mentor mothers are selected based on the fact that, one, they are people that have first-hand experience of being somebody living with HIV and have passed through the PMTCT program with success stories of having negative babies. Secondly, they are willing to disclose their status to other women that are HIV positive Above all, there must be that willingness on the side of the mentor mother, and then she must have the time, because she needs the time to work at the facility and also visit the clients at the community. Another criteria we look at is that the mentor mother has to be from the facility where she is going to be a mentor, because it's important that she know the group of people she is dealing with. It's important that she understands how it works. And most of the times you discover that most of the clients in a particular facility are from that community. And so it makes it easier for her to reach out to them without much fear of stigmatization.
When the IHVM bring the information that they need volunteers, yes, I came out to be one of the volunteers because I don't want women to suffer, because when their baby come out, they are positive, and when their baby come out positive again, it will not become an easy thing for them. To come and collect their drugs alone, they will be thinking, how many will I come and how will I do to come and collect my drugs? Talk less of when baby comes out positive again. How can they feel? That's why I took up the things. I said, I will make sure that no woman I mentored that will come out, the baby will come out positive. So that's why I came out to say, I want to be a mentor mother.
A mentor mother is often preferably selected from the local mother-to-mother support group and is based on certain criteria.
At recruitment of these mentor mothers, we give them a comprehensive 3-day training that runs across all the basics of HIV and PMTCT. We also discuss, as part of the training, tracking. We also discuss communication, because the way you talk and how you need to rephrase certain things to make clients understand. So we train them on home visits and what care of the patients outside the facility. But after that, we do on-site mentoring. We have our program staff across all the facilities that work with these mentor mothers to follow up on their activities, train and mentor as the case may be. Where there are places they don't or things they don't understand, we put them through. So it is not a one-off thing, it's a continuous process. As they work within the facility, there are people that guide them. There are people that monitor and mentor what they do. But those are the things we do. We do that at recruitment, and we also do that on annual basis. We give them orientations on annual basis to refreshing their minds on the new things that are evolving in the PMTCT program.
A mentor mother provides a wide range of facility and community-based services in support of HIV-positive mothers and their exposed infants, ranging from pre-delivery through delivery and postpartum periods.
When, like, on Mondays, we have to register new patients, new PMTCT mothers that is positive. They are pregnant, they will come for antenatal, then we register antenatal. Through there, we will pick them out. We will bring them here in this office, mentor mother office. Then we talk to them what they will do so that when they give birth to their baby will come out negative. The baby will not come out positive. Meanwhile, I have never mentored any mother, the baby come out positive. All of them is negative. Then after we send her for the test, we will now write septylin for the baby. She will go and collect the septylin. She will continue giving that baby the septylin and continue breastfeeding the baby until 9 months. When the baby is 9 months, the mother will bring the baby back. We will conduct another test for the baby. We call that one first rapid test. Then when the baby do the test, whether it's positive or it's negative, we don't mind. Because why we are doing it like that, some children, they are still sucking breast, they will come out negative. Some, they will still sucking breast, they will come out positive because of the mother antibody is still with the baby. But after 9 months, when the baby is 1 year and 3 months, we will conduct another test again, which we call second DBS test. Then, if we do the test, the baby will come out negative. You can see that the 9-month-old did not work again now because of the mother antibody. Then, after that one, 1 year, the woman will stop the baby breastfeeding. Then she will start from 3 months, she will bring the baby. Then we will conduct the second test for her, second EID for her. Then it will become 3 tests. After that one, we will give her another 3 months again to go back. That time, the baby, everything the baby sucked from the mother is out. Then the baby is 1 year and 6 months, which is 18 months. The mother will bring the baby again for what we call final outcome. When the mother comes, then we will test the baby with kits again. Then that one we call it rapid test, the final test for the baby. Then the baby will not come out negative. Then we will close the chapter of the baby and the mother. Then till when the mother take in again, she will now come back again. We will mention her.
Antenatal care is one of the major platforms for PMTCT service delivery.
Why we want them to come to antenatal? Because the baby can still be infected when the baby is inside the womb, when the baby is breastfeeding, and through delivery. If she did not know her status, when she came for antenatal, then register her in antenatal, we discover her there, we can put her on drugs, put her through PMTCT, prevention of mother-to-child transmission. Then after that one, the baby can be infected through delivery. Because that's why we tell them, don't deliver at home. Because you can deliver at home, when the baby is coming out, the baby can suck blood. The baby can suck water that is coming out of the mother. Then, when the baby suck that in, nobody will take care of that baby at home. Definitely the baby will be infected. Another chance for the baby to be infected through breastfeeding. Because the breast milk the baby is sucking, the thing is there. Now, when the mother is breastfeeding, the mother is not supposed to give the baby breastfeeding and milk together when the baby is from one day. The day that the mother gave birth to the baby will take only breast milk till 6 months. We call it exclusive breastfeeding. No abo, no concussion, no water until the baby is 6 months. Then when the baby is 6 months, the mother can start introducing the baby to food, soup, water, but she will never feed that baby with milk. Artificial milk and breast milk, they don't go together. So she cannot give. Any baby that take milk and breastfeeding, the baby can come out positive.
Unequal access to HIV prevention and treatment services perpetuate HIV among vulnerable population groups. This year's World AIDS Day seeks to equalize access across populations that are marginalized among vulnerable and key affected population groups by removing economic, social, cultural, and legal barriers to HIV prevention services across population groups that are vulnerable to HIV. Globally, we call for equalize. Locally, we say equalize to end AIDS.
Sister! Where you dey rush dey go like this now? Take am easy now.
Na hospital I dey go to do HIV test.
Na everything you dey do HIV test. Before you carry belle, you do HIV test. Now you dey rush go do another HIV test. Wetin you dey find, you go see am o.
No be so, my sister. HIV test no be bad thing o. Na make I know my status so that no matter the result, my pikin no go get HIV.
HIV fit pass from mama to pikin?
Yes o, during pregnancy or labour or even when we dey breastfeed the pikin. Yes, and my husband dey road dey come sef, he go meet me for hospital. We go do the test together.
Hey, your husband na man he be. But wait o, una no dey fear. What if the result come out positive?
Fear wetin na? HIV no be death sen ten ce. And medicine don dey to take manage am. See, nowadays, people wey get HIV, they live their life normal like everybody else.
You sure say I no go follow you go do my own so?
Wetin you dey wait for now? Come make we go, jare. With quick action, we fit stop this HIV waka from mama to pikin. Go do your own HIV test today.
The issue of sustainability is one of the challenges the Mentor Mother program faces.
The major challenge we are envisaging is sustainability. How to sustain the Mentor Mothers activities beyond donor fundings. When there's no longer fundings coming to the donors in country, what happens? Do we stop the Mentor Mother activities? Because as it is, all the Mentor Mothers in program are being supported by this institute, to pay their transportation and, have communications across their activities. So I will want to suggest that the federal government, the state government should come up and, embrace this program, because it has proved that with the Mentor Mothers, we have high level of retention of patients in care. We have high level of, care for the women, and the prevention of mother-to-child transmission cannot effectively succeed without their services. And so if this is working so well for us, we need to look at it the second time and come up with modalities to, fit this into our policies within the country.
The challenges exist because we are human beings. Sometimes the mothers, you will give them appointment to bring the baby. They will not bring the baby. But we know how to follow them up. From the day one, we will collect their phone number, collect their address, collect everything, how church, anything that is closer to your house, that will make us, when we trust you come, we will get you. We started with that one first. Yeah, it's working, but it's not working well. Because sometimes we will call them on phone. You're supposed to bring this baby today, but I have not seen you. It's okay, madam, tomorrow I will come. Can I come to the house and meet you and take the baby sample? She will say yes. She will give you address to Masaka. When you get to Masaka, she will switch off the phone. You will be stranded. When you look and you will not see the baby, you will come back. When you come back, you will continue tracking until you get the woman. She will bring the baby, then you will attend to her. Then we come up to see that way is not working out well. Now when you come, we will talk to you and we will tell you that if you miss the baby appointment, if we give you 6 next month, you deliver this month on 7th of September, you are supposed to bring your baby again in 6 weeks time. You see that when you are waiting for them that 6 weeks time, they may be doing you like this. Then the time of that test will pass. Then we now give them one month. And when we give them the 1 month, before that 1 month to that 6 months, we will track them up, then we bring the child. And another thing we did to them that give us normal outcome now, we will charge them. We will tell them that if you refuse to bring this baby, you will pay 5,000 naira. Then where can I get the 5,000? So I will give to that appointment. You understand? Then before the appointment in 2 days' time, we will call that person to remind you that you are coming for your baby appointment. And if you refuse to come, you know that you will pay 5,000. Say, hey, auntie, I will come and will bring the baby. She will bring the baby. Then the day that she's supposed to come, we will call that person in the morning. As today now, you call that person, say, bring your baby. You say, I'm coming, I'm on my way. Then you bring the baby, we will do the test.
Poverty, a major driver of HIV, also poses a strong challenge to the Mentor Mother program.
before they are registering antenatal cheap. You know, sometimes the women, they will say that they don't have money to register antenatal. You understand? When they come to the antenatal with 2,000 naira, then they will register. Some of them, we help them to contribute the money because we don't want their baby to come out positive. Some say they will tell you that they don't have anything. We will say, okay, come. We will help you. Women turn mothers, we register that person, follow her up. She gives birth. She will deliver her baby. But now, the amount of money they are using to register for antenatal is much. So some of them, you will talk. They will not agree to register. They will say the husband don't have money to register for the antenatal. But if it's free antenatal, yes, they will come. They will register. You understand? But this one, you will talk. They will tell you that I want to register, but I don't have money. And we, by then, maybe the time the woman need to register the antenatal, we don't have money to support the woman. But if the antenatal is free, she will register. Because there is sometimes they used to do before 1,000 naira. Now this test 1,050 naira or 1,2. Now the test is 2,050 naira. Then the person that the husband don't have money to register, it's only the test, so you will still go for scanning. You will still do another test like hepatitis and others, but they will say they don't have the money. But if all these things is free, why wouldn't they come? Sometimes you will call the women. Some are ashamed to tell you that I don't have transport. You understand? But when you call her today, call her tomorrow, the next day, you will sense it by yourself. You say, Madam, open up, tell me your problem. She will say, okay, auntie, I don't have transport. You say, oh, yeah. Where are you coming from? She will tell us. If it's the one, because I have to tell you the truth, the one we can afford, she will say, okay, madam, come, we will give you the transport.
Mentor mothers are an acceptable PMTCT intervention among stakeholders in Nigeria. However, stigma and discrimination for both mentor mothers and their clients remain a critical challenge, and mentor mother needs such as continuous training, robust welfare package, and a sustainably supported niche in health systems require focused attention.
Every year on the 1st of December, we mark World AIDS Day. This year, the global theme is Equalize, but we have domesticated the theme, which is Equalize to end AIDS, equal access to prevention and treatment services. We have so many activities, inclusive of HIV testing services, road shows, adolescents and young people activities, technical sessions looking to address issues around gender and rights, testing and treatment uptake. We also will be looking at issues that have to do with accessible testing and optimized treatments and comprehensive care for infants living with and exposed to HIV/AIDS. And finally, we have a major event on the day of the World Day itself on the 1st. And then we'll be having launch of strategic documents, and we'll have key partners also giving messages, speaking to the team. We believe if we equalize, we'll be able to take care of issues around inequalities among the marginalized and key population, and end this before the year 2030.
For more information on HIV and AIDS and related diseases, or to report suspected cases of stigma and discrimination, violence and human rights violation, please call the National Call Center toll-free on 6222. Reach us via social media at National Call Center or email callcenter@naca.gov.ng and visit our website on naca.gov.ng. Thanks for watching, and as we draw closer to the 2022 World AIDS Day celebration on December 1st. Let us equalize to end AIDS. Do not stigmatize or discriminate people living with HIV. And lastly, know your status and take action. Till next week, on The Last Mile with NACA, I am Adesu Welsi. Goodbye.